Today's lecture is on MRI artifacts and quality control. After today's lecture, students will know about different artifacts and their causes, and also learn about MRI quality control and accreditation. We shall finish up with MRI safety education and safety zones. Artifacts in MRI may be broadly categorized as machine-dependent or patient-dependent, but these are not mutually exclusive. The same artifact may be due to either machine-related effects or patient-related effects. An example are artifacts related to inhomogeneities. Artifacts may also appear due to the way the image is processed. We shall start with machine-dependent artifacts due to inhomogeneities on this slide. Inhomogeneities result in artifacts that appear as low and high contrast areas in an image or as geometric distortions in the frequency and code direction. When the magnetic field is not homogeneous, the flux lines are not parallel. So when data is read out and mapped onto an orthogonal or square grid, the data is deformed in the frequency encode direction. Recall that the frequency encode direction is also the readout gradient direction. Magnetic field inhomogeneities may be due to large static field inhomogeneities or due to metallic objects in the patient. If the inhomogeneity is due to static fields, then proper site planning, self-shielded magnets, automatic shimming, and preventive maintenance procedures help to reduce these inhomogeneities. In the case that the inhomogeneity is due to a metal object in the patient, the choice of pulse sequence can help reduce the artifact. For example, we learned that spin echo pulse sequences are less susceptible to magnetic field inhomogeneities and to susceptibility artifacts. This is because of the use of the 180-degree refocusing pulse. On the other hand, the gradient record echo pulse sequence accentuates artifacts from inhomogeneities. Magnetic susceptibility is the ratio of the induced internal magnetization in a tissue to the external magnetic field. So as long as the magnetic susceptibility of the tissue being imaged is unchanged across the field of view, the magnetic field will remain homogeneous. Tissue susceptibility changes occur at tissue-air interfaces due to rapid dephasing at the interface because of fast T2 star decay. This leads to a loss of signal at the interface. The presence of any metal object will cause distortion of the magnetic field and affect tissue due to changes in susceptibility. Also, the presence of paramagnetic blood degradation products and gadolinium can cause a significant decrease in T2 star relaxation. The images show signal loss in the T2 star image due to rapid dephasing of T2 star signals. By using a fast spin echo sequence with a 180-degree refocusing pulse, the signal loss is reduced as shown in the left image. Gradient field artifacts are caused by gradient nonlinearities that cause image distortions when anatomy is mismapped. Gradient fields are used to encode the spatial location of signals, so gradients have to be properly matched. Gradients typically fall off at the edges of the field of view, so when a large field of view is used on the order of greater than 35 centimeters, there is a possibility of image distortions that are especially pronounced on the coronal and sagittal images. The remedy is to reduce the field of view by lowering the gradient strength or by keeping the gradient strength constant but decreasing the bandwidth. It is also important to properly place the frequency encode gradient along the long axis of the patient and the phase encode gradient along the short axis of the patient. The two lower images show distorted images due to gradient nonlinearities. RF coils can produce variations in uniformity across the image because of attenuation of the RF signal, sensitivity fall-off with distance, and excitation variability. These are corrected by proper tuning of the RF coils before the image is acquired. These images show areas of intensity due to the surface coil being close to the skin. Another source of RF coil artifacts is the quadrature coils. Quadrature coils are used to collect signals from orthogonal views simultaneously. This speeds up acquisition and improves signal-to-noise ratio. But if the amplifiers used for the coils are unbalanced, diagonal ghosting of the image can occur. RF artifacts caused by stray RF signals from sources like radios, fluorescent lights, power equipment, and other instruments have to be blocked out of the MRI scan room. These signals can be detected by the receive coils and cause artifacts like the narrow band pattern of black and white zipper artifacts shown in the top image. If the RF noise is broadband, it causes a herringbone artifact over large areas of the image, like in the top right images. RF artifacts are reduced by having proper RF shielding of the magnet room. RF fingers on the doors provide the necessary shielding. Recall that K-space is the matrix of frequency information used to collect the RF signals. A single bad pixel in K-space can cause significant image artifacts. In this image, a bad pixel is shown at the center of K-space, showing the effect on the image on the right. Remember that most of the image information is at the center of K-space, and also that each data point in K-space is a wave containing a particular phase and frequency. So it will have a wave-like appearance when it is out of place and reconstructed as part of the image. Motion artifacts are the most common artifacts and are caused by both voluntary and involuntary motion and flow from blood and CSF. Most motion artifacts occur along the phase encode direction, as is shown on most of the images on this slide. One way to reduce motion artifacts is by swapping the frequency encode gradient and the phase encode gradient directions, but this is not ideal because it leads to increased acquisition times. Other methods of reducing motion artifacts are cardiac and respiratory gating, signal averaging, and using short spin echo pulse sequences, among others. There are two types of chemical shift artifacts, a chemical shift of the first kind and a chemical shift of the second kind. Chemical shift artifacts of the first kind occur because of resonance frequency variations between protons in fat and water, or protons in silicon and protons in water. Because resonance frequency increases linearly with field strength according to the Lamour equation, higher field strength magnets are more susceptible to chemical shift artifacts. Protons in fat resonate at a slightly lower frequency than the corresponding protons in water and cause a misregistration of water and fat tissues along the frequency encode gradient directions. Chemical shift artifacts can be reduced by using a lower gradient strength and narrow bandwidths in combination with off-resonance chemical pre-saturation RF pulses to reduce the signals from the fat or silicon. An alternative is to use short tau inversion recovery techniques to eliminate the signals due to fat at the bounce point. Swapping phase and frequency gradient directions or changing the polarity of the frequency encode gradient can displace chemical shift artifacts from a specific image region, even though the chemical shift still exists. Chemical shift artifacts of the second kind occur with gradient echo images due to phase differences resulting from rephasing and dephasing of the echo in the same direction relative to the main magnetic field. It is due to constructive and destructive interference. The first image shows constructive interference between fat and water at 9 milliseconds echo time, and the bright signal at the interface between fat and water is shown. In the second image, the signal at the fat-water interface is low due to destructive interference. Ringing artifacts are also called Gibbs artifacts and are caused by insufficient sampling of high-frequency data inherent at sharp boundaries. It appears as alternating light and dark parallel bands. The effects of Gibbs ringing can be mitigated by applying a filter function prior to Fourier transform. The trade-off is a reduction in spatial resolution. A wraparound artifact is a result of mismapping of anatomy that lies outside of the field of view. The mismapped anatomy is usually displaced to the opposite side of the image as shown in this slide. It is caused by undersampling of the frequencies in the signal. If it occurs in the frequency encode gradient direction, it can be corrected by applying a low-pass filter. If it occurs in the phase encode gradient direction, it can be corrected by increasing the number of phase encode gradient steps, essentially increasing the field of view. Now let's look at accreditation, quality control, and quality improvement. Quality control of imaging equipment is an important part of any imaging department. Qualitative and quantitative measurements of system performance should be performed on a periodic basis. The various components of the MRI system that must be checked periodically include items listed on this slide: the magnetic field strength, field homogeneity, system shimming, gradient linearity, RF tuning, receiver coil optimization, location of noise sources, power supplies, and control systems should all be checked periodically. These tests can be done with a manufacturer's phantom. Also, other manufacturer-designated tests may be done to check the performance of the MRI system. Apart from the QC program mentioned on the previous slide, quality improvements in the imaging program can be achieved by gaining accreditation through the American College of Radiology (ACR). The ACR accreditation program evaluates the qualifications of personnel, equipment performance, effectiveness of QC procedures, and quality of clinical images. The process involves submitting phantom and clinical images for review. The phantom images are acquired using the ACR phantom shown on this slide. The ACR phantom has several objects for testing of geometric accuracy, high contrast spatial resolution, slice thickness accuracy, slice position accuracy, image intensity uniformity, percent signal ghosting, and low contrast object detectability. Magnet safety education is an important part of a good MR imaging program. Anyone who works in an area of the hospital where there is a magnet should be educated and trained on magnet safety. It is particularly important for hospital clinical staff, maintenance and janitorial personnel, law enforcement personnel, fire department personnel, and anyone else entering the scan room or working near the magnet to have some level of MR safety education and training. On the next slides, we shall learn about MR personnel education and MR zones. The magnet safety training and education that staff working near the magnet receive classifies them as either Level 1 personnel or Level 2 personnel. Level 1 MR personnel have passed the basic MR safety course and have a basic understanding of the effects of MR magnets, dangers of projectiles, and the effects of strong magnetic fields on objects. These individuals can work in Zone 3. Examples are MR office staff, patient aides, and custodial staff. Level 2 MR personnel have passed the advanced MR safety training and understand the potential for thermal loading, burns, neuromuscular excitation, and induced currents from gradients. These individuals are the gatekeepers of access into Zone 4. They can take action and perform leadership roles in the event of a patient code, ensuring that only properly screened support staff are allowed access. We shall learn more about MR safety and bioeffects in a different lecture. MRI zones are shown on this slide. Zone 1 refers to common areas with unrestricted access. Zone 2 are patient reception areas or patient dressing and holding areas. This is an unrestricted area. Initial screening can take place in this zone. Zone 3 is a restricted access area and usually includes the door to Zone 4. Final screening takes place in Zone 3 before entering Zone 4. Zone 4 is the magnet scan room. It is restricted access and under the control of Level 2 MR personnel. This is the last slide. Thank you for watching this presentation.